And I think also one of the questions in the chat, but we can deal with that during the panel discussion, is, of course, you mentioned the more you look, the more you see. But if you don't have the tools to look at it, what would you do? How to use antibiotics in a rational way if you don't have access to microbiology? But that's something we can discuss later on in the panel discussion. Now, before moving to that panel discussion, there was one question, maybe a question for clarification from Mike from his presentation, from somebody in the chat saying the worrying results of PPS in the UK, actually, because it's not only a matter of low resource settings, but also in the UK, you see quite a high number of watch antibiotics used. So, and the second question was, what about COVID? What was the impact of COVID on antibiotic use? So, Mike, I don't know if you want to just briefly explain a bit.
Thank you, Rashid. And I think it's actually really important to emphasize that broad spectrum, the overuse of broad spectrum antibiotics is not a low middle income or a high income. There are many high income countries that actually have very good control of their antibiotic policies and use narrow spectrum antibiotics. And there are very many good lower middle income countries, and there are very many bad high income countries that have almost very little control over their policies, and the same for lower middle income countries. So in fact, if you look at the ratio between access and watch use, and you consider those ratios, they're identical in LMIC and high income groups, which is really interesting. So this is unlike many other conditions. So yes, the UK is not so great, and we have a high use of broad spectrum antibiotics in children admitted to hospital, an inappropriate high use, and indeed have government policies which are trying to reduce that at the moment. And in fact, we have a National Health Service policy to reduce access, to try and make 55% of all access, all antibiotics in hospital settings are access antibiotics, which we can come on to discuss as well. COVID is complicated. So in some senses, people haven't been able to see doctors in many settings because of the restrictions associated with COVID. And the biggest risk of getting an antibiotic is to see somebody who gives you an antibiotic. If you don't see anybody, then you don't get an antibiotic. Equally, a lot of broad spectrum antibiotics have been used for minor infections, respiratory infections, despite the WHO guideline being obviously not to prescribe in the community setting as well. So COVID is complicated. It will take a couple of years or so before we'll really know what the impact is. And there's quite a lot of interesting research in this area. Thanks, Jorgen.
Okay, thanks for the clarification and explanation. So I think we have now seen, first of all, the field reality from two MSF contexts with the challenge of not having microbiology, but still having some tools to implement. Also the perspective from Mike on the different categories of antibiotics and the issue of antibiotic use and antibiotic resistance. And then, of course, the challenges related to IPC and outbreaks in the last presentation. So with this, I propose then to go to the panel now. So we have, of course, Mike and Uduak in the panel, but we have some extra people as well, and I will briefly introduce them. So we have Jane Davies in the panel. She has a Bachelor in Science in Nursing and a Master in Science in Public Health, and joined MSF back in 2017, first as IPC manager, but then moved to headquarters, as an IPC implementation advisor, and now currently is into IPC, AMR, and nursing implementation advisor. And she's really passionate about this topic and strives to raise the profile and activities in these areas in our projects and with our teams. Then we have Dr. Nada Malou, as a PhD in microbiology, and she has spent several years on the field with MSF, implementing microbiology laboratories in Mali, Jordan, Yemen, and then joined the medical department of MSF OCP as lab advisor and as bacteriology and ABR advisor. And then in that position, she also supervised implementation of microbiology labs in CAR, Liberia, Gaza, Yemen, Iraq, and Lebanon. So that's quite an impressive list. And also collaborated with the ABR task force. And then in 2016, she joined the MSF Foundation to create Antimicrobial. I don't know if I pronounced that one correctly, which is an open access, free and offline smartphone-based application that allows the reading and interpretation of antibiograms by non-expert lab technicians. And so this development continues, but since 2020, October 2020, she is now with the AMR team of FIND, and FIND is the Foundation for Innovative New Diagnostics. And then the next panel member is Dr. Amel Filali. She's infectious diseases doctor trained in France and was working for MSF in CAR, implementing a stewardship program there, and then moved to the medical department of MSF OCP as an infectious disease specialist and ABR reference. And she also holds a master's degree in geopolitics with specialization in the geopolitics of pandemics. So that's the 5 panel members. So I propose to start the panel discussion now. And maybe the first question to start with is for maybe for Jane. It's about SIPCA. So we saw the video of the BenQ team implementing SIPCA, improving activities for based on SIPCA results. But yeah, can you maybe elaborate a bit more? What challenges do you see for the field teams to manage this assessment? Because doing the assessment is one thing, it takes time, it takes maybe some expertise. So what has been the added value of the use of this tool from your experience in MSF projects in general? Thank you.
Thanks, Jorgen. The SIPCA tool is a IPC assessment tool, and it looks at things in a stepwise approach. So we know that there's always problems in any healthcare facility around having very good IPC practices. And this tool is an assessment tool that can help projects track where they are. So see what their status is now and hopefully improve in the future. One of the things that, for example, BenQ has come across is that maybe in malaria season, they get a very high number of pediatrics that they wouldn't normally see. And so their bed occupancy goes up. Therefore, when they do the assessment at that time, we expect that their rate would drop a little. So that's reflecting the actual trend of what they're seeing in the hospital at that moment. What the SIPCA tool can do is just help monitor the trend over time and give a flavour for what actions or activities can be put in place to try and improve things. For example, the presence of an IPC committee that's meeting regularly, that's multidisciplinary, and with actions and activities can also be fed back into the SIPCA and then raise the results of the SIPCA over time. One of the things that we need to be sure of is that when our patients come to our care, that we don't expose them to something that could give them an infection, whether it's on a healthcare worker hands, that they're not being done appropriate hand hygiene before they're accessing an IV cannula, or they're being put into patient, in these times where there's a surge capacity, where there's a lot of pediatrics, that they're putting into the same bed as another patient and their caretakers. So often we have not just one patient and a caretaker per bed, but sometimes 4 or 6 people per bed. You can put obviously the same family group in the bed if there's a mum with 2 children, but really we want to make sure that we're not putting our patients at risk. The ability to do proper cleaning and disinfection when we've got multiple children in one bed, it's really impossible for the teams to manage. So there's lots of bonuses for the SIPCA and trying to get this stepwise approach and tracking of how we're doing in our projects. It's intersectional, so it's used across all the sections, and there's a dashboard so you can compare your results over time and to other projects. And it's also important to feed that back to the team on, are we improving or are we actually not improving?
Okay, thank you, Jane. I think it's indeed important to use the results. It's just not about the tool, but it's also how are you going to use the results of the tool to improve practice. I don't know, Uduak, if you want to just maybe complement this, because Jane mentioned something about couple of children per bed and the challenges for IPC, and I think on your picture as well in your presentations. I don't know if you want to add something on this one and the challenges related to this.
Yes, thank you. I think that really is a challenge, and there's really no straightforward answer to that because it also depends on the setting. And so you have one hospital, and I like the hospital I showed, it's against the hospital's policy to turn patients away. And so, and if that's the only neonatal unit, then, you know, it's difficult to really enforce one patient per bed. But I think bearing in mind the risk of infection transmission, I think where we need to be careful is with hand hygiene, the invasive devices that we're using, the procedures, and try as much as possible to do our best to prevent the cross spread of infection. But it's really a challenge in some settings. It's not as easy as just saying, okay, one patient per bed, everybody else goes. Where do they go to? And if they do need facility-based care, then it's a challenge. Sometimes we bring in more cots. So at peak season, our neonatal units, the main ward for sick babies takes about 30 cots. But in peak seasons, you know, we can have up to about 40 to 50 to 60 cots in that space, which is also a challenge for just cleaning and, you know, and all of that infection control. So it's a challenge, but we can do our best.
Okay, thank you. Another question is about the other tool that was shown in the videos, the point prevalence survey that also the team in Bentiu has done and also in Mali. So maybe a question for Amel this time. So yeah, how do you see the deployment of this tool? I mean, how to implement this tool, how to use it, and did that change really practice? So do prescriptions improve? Do clinicians accept the results of these point prevalence surveys? So I don't know if you can elaborate a bit more on the challenges of these PPS and the added value of PPS.
Oui, bien sûr. Alors, c'est vrai que le PPS est très intéressant dans le contexte MSF parce que dans nos projets, souvent
It's very interesting to use PPS in the MSF context because the workload is quite often huge and we do not have the human resources to monitor very closely antibiotic use, and PPS allows to have a snapshot of the prevalence of antibiotic use and the quality of its use. And it doesn't need that much resources to perform a PPS, but it has to be made by a multidisciplinary team, because then the results and the findings will be accepted rather than having one person performing the survey. It's better to have everybody involved and discuss with the team and have an anonymous survey carried out. It's very interesting within MSF to have PPSs because they can be repeated by different teams with the same PPS protocol, because sometimes we have a high turnover of staff in our project. So it helps to have a kind of longitudinal surveys. And also the first benefit of PPS is that it helps, it's a tool for awareness raising. That's the main primary function of PPSs. And then it helps you to draft a plan. And when you want to start a stewardship, having a PPS helps to plan and to define an action plan and to reassess afterwards. So it can be very useful for the teams, and it's widely commonly accepted.
Okay, thanks. Thanks indeed, Amel. So I think you mentioned, well, the multidisciplinary approach is not just about the clinician. I think everybody's involved, I think, and in resource settings, nurses are prescribing as well. So I think it's important to have the different disciplines involved. Mike, you also mentioned PPS. So I don't know if you want to add something to the added value of PPS, the implementation of PPS, the use of PPS.
Thanks, Jorgen. I think it's very important and very difficult because it is quite easy to, or it is not easy, but it is possible to do this, to go around the ward and to work out, what patients are, particularly if you use the access, watch, reserve, and therefore you're only asking proportions, as we were showing in the slides, what green antibiotics, yellow and red, and what proportions. It's quite useful for getting centers to look at their data to start off with, because it provides interesting feedback, and also you can look at it over time. It tends to stay fairly stable, actually, quite interestingly. In many hospitals, it stays stable quite a long time, and we've done centers for many years. What is very difficult is to change anything. And that's the problem, because as everybody has pointed out, it is easier just to do that. And in fact, we wrote a paper recently saying that the point prevalence survey could be called the particularly pointless survey, because nobody changes anything. And that is the reason for that is often structural, to do with cost, to do with drug availability, to do with attitudes, and so that makes it very difficult. So I think as a stewardship tool to get people to look at their data, understand their data, do comparison between hospitals with similar caseloads, it's very helpful. And what we need to get better at is trying to then follow up and boost the implementation, the change implementation. Thanks.
Okay, thanks, Mike. And also thanks for the new abbreviation for the PPS, the particularly pointless search. I was not aware. Thanks a lot. So I think the whole discussion about antibiotic stewardship without having access to cultures, we can keep that for later on. Maybe also a question for Nala is about microbiology, and as well as the Mali video clearly showed, microbiology has added value because it documents the problem, it creates awareness, you can improve patient management, it gives you surveillance data, etc. But it is, of course, still challenging to implement in MSF projects. So can you just maybe also from your point of view, as you have been implementing so many microbiology labs, maybe elaborate a bit more on the challenges of these labs and how does it impact clinical practice? Thank you.
Merci, Jorgen. La difficulté de la mise en place des laboratoires.
The difficulty of introducing labs, of course, you have all the problem of procurement, supply,
la structure, puisqu'il est nécessaire d'avoir
structure, because you need to have standard compliant laboratories. But the striking things when we have implemented microbiology lab at OCP, the main difficulty is to assess the impact on patient management and also IPC and hygiene. Before having a microbiology lab, we were not aware of the fact that there were multi-resistant bacteria and that there were hospital-induced diseases. And as soon as the labs were set up, we were faced with these problems, and the clinicians and the nurses were not trained to manage these multi-resistant bacteria and these diseases. Same thing on the clinician side, who have been trained at the university on antibiotic spectrum, but they never actually practice it because access to microbiology lab was rather limited in these settings where MSF is present. So it was a whole challenge to find the right way to train the clinicians on the proper use of the lab results and properly prescribe the antibiotics. When it comes to the impact of microbiology lab in our programs, one of the challenges that we have identified is the difficulty to measure the impact on the outcome of patients. With a qualitative approach in all these programs, we've had these labs, we've noticed that there was a better awareness amongst clinicians on ABR. Everybody is aware of the fact that it is a major public health issue, but for a very long time, clinicians thought that it was, specific to Northern Hemisphere countries, developed countries, But introducing such a lab has made them aware of the fact that this problem also exists in their settings. The second positive impact of such an introduction is the fact that clinicians have started to think on either cascading up or de-escalating the drugs they were prescribing. Then there's the obvious impact on IPC and hygiene. As soon as you reveal the presence of multi-resistant bacteria, you highlight a hygiene problem, so you put the emphasis on hygiene procedures to prevent hospital-induced infections. And microbiology also has helped to reinforce the role of pharmacists, because for some time the pharmacists quite often were considered only as the warehouse manager with little contact with others, while now they are working with the microlab, with the clinicians to check the dosages, the management, and the stewardship of the drugs. And I'm the champion of a microbiology lab, of course, but it helps to foster multidisciplinary work because it puts down the silos, because it will be helping IPC to isolate the patients in time and to send out the results to the pharmacists so that they will make the drugs available in a timely fashion. So it has helped to foster multidisciplinary work, and which is absolutely key when it comes to ABR.
Thanks, Nada. I think you raised a couple of interesting and essential points as well. I think, first of all, the training, which is important. I think not just maybe the training of clinicians, but I think in general, more training of our healthcare workers on the different aspects of antimicrobial resistance is really, really important. I think it also highlights the need, the link between clinicians and the lab, because just having a lab is not enough. Clinicians need to be trained how to use the results. And I think also something that was mentioned is the role of the pharmacist in this, because we speak about multidisciplinary approach. Again, it's not just the clinician, but everybody, like pharmacists, have a role to play. There was one question for you, Nada, as well. When in the beginning of the lab it was implemented, how did it go with the requests for culture from blood culture from clinicians? How was the start actually? Did you have lots of requests? Or was it a difficult start?
C'est une excellente question.
That's a very good question. It was a nightmare. It was in Mali the first time when we had this. And this was quite a learning experience for the deployment of other labs as well. When we started, there was no algorithm on the prescription of blood cultures. And we realized there was a very high number of clinicians who were asking for it. When they didn't know what to do, they were prescribing a blood culture. So there was a high number of blood culture requests, but the positive cases were very low. The number of positive cases were very low. So we said we need to work on prescriptions. We worked with the infection specialists and pediatricians to have an algorithm leading to define the need for blood culture. And thanks to this algorithm, we have been able to make sure that it would be a rational use of blood cultures, that we've streamlined the blood cultures. And in spite of this, the robustness of this algorithm in the field, it's very important to monitor the blood culture prescriptions and the number of those and the rationale for such prescriptions over time, to give a boost to clinicians and say that they have to stick to the, let's say, best practices and the most rational practices.
Okay, thanks for that clarification. Another question that came in was for Uduak and Jane, is about the definition or operational definition of nosocomial infection. So which operational definition did you use for nosocomial infection in your study?
Thank you for that question. So Usually, hospital-acquired infections would be classified as those that occur maybe after 72 hours of admission. But for this study, this study wasn't initially set out to detect an outbreak. So this was a study that was set up to investigate babies with suspected sepsis and to find out what the causes of infection were. And so we had strict inclusion and exclusion criteria for babies who had signs and symptoms suggestive of possible infection based on the WHO criteria. And these babies had a blood culture at admission or before the start of antibiotics or within 24 hours of admission for those that were admitted overnight. Obviously, some babies were referred in from other hospitals where they probably had received antibiotics before, but this was captured in the study. Now, the issue of the outbreak arose when we saw an increase in the number of cases with these particular pathogens. And so that's when we now decided to look at the antimicrobial profile of these pathogens and saw that the resistance profile, that they were similar. And so we suspected that we must have an outbreak. And then we now retrospectively analyzed this data. Obviously, some of the babies presented with infection on the day of birth, on the day of presentation, which was interesting. And that's why we were able to we decided to look at the environmental samples to find out, okay, are these really community acquired infections, or is there something going on in the environment? Obviously, one of the limitations is that we didn't take environmental samples from the neonatal unit, from the maternity unit, to see if this could have been the source of infection for the babies that were presenting on the day of birth. I hope I've answered the question.
Yes, okay, thanks. Jane, I don't know if you want to add on this one.
This one's particularly hard in a lot of our settings. Because we don't have the diagnostics, it's very difficult to absolutely distinguish that something is definitely a healthcare associated infection. I think sometimes in some sections they're a little bit further along and have got the ability to diagnose outbreaks, and therefore using diagnostics to find and make that call. But often in our sites where there's no diagnostics available, then it's the presumption that this is an infection that the child didn't come into hospital with, or, for example, they were born in the hospital and they've gone on to become unwell with the infectious type syndrome or illness, that we can presume that they've acquired it in the health system. So really difficult. I know that Infection Prevention Control Contact Group and the Nursing Care Working Group have been working together with this, and Surgical Working Group as well, thinking about what does catheter-related bloodstream infection associated with invasive devices look like, and how do we monitor for that in most of our settings. Also, how do we, from the Nursing Care Group, how do we make sure that we're putting in those IV cannulas in a safe and considered way so that we're not introducing infection? How do we do our medication administration preparation? What does that look like? And what's the journey of care to make sure that we're keeping our pediatrics as safe as possible? And surgical site infection at some point will be hopefully an intersectional approach on how do we monitor that, because at the moment we know that even trying to get a clear assessment tool that's accepted by all sites in the variety of sites that we work in is quite difficult. So a bit of a difficult one. The work's ongoing, and I know that many projects have got something locally that they've formulated that can give them an indication within their own project according to their own services of that's also helping them track to see if there's a problem area or a risk for their pediatrics or neonates.
Okay, thanks Jane and Uduak for the clarifications. More questions are coming in, and I see two questions for Mike and Amel. I'll start with the first one. A question saying, should MSF shift more towards Ampigenta instead of ceftriaxone for first-line treatment where recommended by WHO?
That's a really good question, Jorgen, and thanks for that. So we've published data recently, and we can happily discuss it later on. And this is very a complicated question. So the relationship between antibiotic concordance, discordance, so whether the antibiotic covers that pathogen or not, and then mortality outcomes, is multifactorial, and of course clearly includes baby level factors. Is the baby small? Is the baby premature? It also includes supportive care factors. Is there oxygen? Is there fluids? Is there other supportive care? And so these then become complex models trying to define the relationship between coverage and outcome at a broad level when you're trying to use your own data to try and actually define what you should be doing in terms of your own local guidelines. Because the other problem with neonates is that at least 90% of babies are blood culture negative. So therefore the number of positive blood cultures is quite small. And to get adequate confidence intervals about different regimens, you need large numbers, unfortunately. And clearly possibly hundreds of blood cultures before you could actually produce tight confidence intervals between different coverage, between different regimens. What we can say is that internationally, the data suggests that ceftriaxone there is very little evidence that ceftriaxone is better than ampicillin and gentamicin. And that looks like that really cuts across pretty much all of that related to the emergence of CTX715 and other genotypes internationally. In certain settings, and so therefore, I think one has to be cautious about in certain settings. In a number of areas, ampicillin gentamicin actually holds up very well in comparison to ceftriaxone. And it did, in the end, I think we're going to have to move towards, in the long run, targeted, much more targeted guidance, which is going to be targeted with simple factors associated with the baby, with the unit as well. But relating local resistance data, I think, is going to be also very complicated, and we're going to need complex models to try and make best use of the data to guide in different regions. Thank you.
Okay, thanks. Not an easy question indeed. Amel, do you want to add something on this?
Simplement qu'effectivement, il y a une telle hétérogénéité des terrains
MSF. Yes, indeed. There are so many different MSF environments, all types of situations, and it's extremely difficult to give you one clear, simple answer to that question. Unfortunately, we don't have the means to issue recommendations for each country, for each environment, because we don't have labs everywhere. We don't have microbiology labs everywhere. But for now, the recommendations that we have are more global in nature, if you will, more general. But you have to bear in mind that the MSF environments are extremely heterogeneous when it comes to NDR, and there is no one answer to that question.
Okay, thanks indeed. So a second question I had was, again, I think for Mike and Amel, and other ones you can join in as well, but the role of the pharmacist. So I think it was already mentioned a couple of times. It's not just about clinicians, nurses, but also the critical role of pharmacists. I think also Nada mentioned. So Mike and Amel, how do you see the role of the pharmacists in antimicrobial resistance?
Very important. We think so. We think pharmacists are fantastic and really important, and pharmacists often know as much, if not more, than the doctors about the antibiotics and the optimal use of antibiotics. So their role is critical, particularly because many pharmacists stay for a long period of time and really understand antibiotic use very well. So I think their role should be increased in terms of stewardship, and indeed, I think pharmacists hopefully should be leading and taking control of many of the pharmacist activities, increasingly in hospitals, but also, of course, working towards outreaching to the community sector as well. I think there is a real need to try and improve antibiotic consumption data. So pharmacists can have a role in looking at actually overall hospital consumption data, as the WHO suggests, and I know MSF does, and then trying to understand that in a much larger context as well. So looking at overall large trends over time. So I think stewardship interventions are really embedded with pharmacists, but it is complex and it is data heavy. So there is, I think, a training issue in terms of trying to make sure that people can understand the data and can actually conduct and help with their own basic analysis of their own data as well. Thanks.
Okay, thanks, Mike. I think we should have had a pharmacist actually in the panel as well, because we don't have a pharmacist in the panel. So for next year, we will have one. Amel, do you want to also say something about the role of the pharmacist? Because in MSF, of course, in our projects, we do not have pharmacists everywhere. So would you see this?
Je crois que voilà, on a tous insisté sur l'importance de la
I think we've all insisted on the fact that we have to have a multidisciplinary approach and the fact that pharmacists play an essential role, even though sometimes this is forgotten. It's, pharmacists help with the prescription because they are specialists in drugs, also with the monitoring of the antibiotic consumption, also side effects monitoring, so they're everywhere. Now, when it comes to MSF, I think that our main problem is that we have very few pharmacist clinicians in our pools, and they have an extremely heavy workload, and they are not always clinicians also. Sometimes they are put aside or they find this stewardship difficult, but there is no reason why we shouldn't involve them, because they are partners and they can take part in solving the problem.
Okay, Nada, I don't know if you want to add, because you also mentioned, I think, something about pharmacists and the role of the pharmacists.
Oui, bah non, j'appuie juste sur la...
No, I just agree with the fact that it's difficult at MSF when it comes to our human resources to find clinical pharmacists. And I think it's extremely important that we also change the way we communicate. We should really involve them in all our strategies. And when it comes to AMR, be it clinicians or the lab, sometimes when we talk about pharmacists, they don't necessarily understand why we talk about the pharmacists and their role in the handling of AMR. So we should really make sure that pharmacists are always involved. And I fully agree with Jorgen. Next time we need to have a pharmacist in the panel. This would also send out an extremely important message.
Thanks for your answers on this question. And maybe linked indirectly to this discussion is, what was also mentioned already a couple of times, is the need for training. So, of course, AMR, antimicrobial resistance, is not an easy topic. We can do stuff, we can do surveys, but we need to interpret these surveys, implement, improve, etc. So I think what needs to be done is also develop training, so to make sure that we have qualified people to do the job, and we don't always have them. So I think it's a question for all of you, but maybe to start with Jane, how in MSF is training developed actually? What is MSF doing? What can we do to make sure that for this rather complex issue such as AMR, we train people in the most appropriate way and we have qualified people?
I think I just want to add to the last point about multidisciplinary team actually, and give a heads up for the nurses as well. There's also a capacity for nurses to be looking at the prescriptions and to be questioning the doctors about the indications and are they documented as well, especially when the nursing supervisors, they know their departments very well. Sometimes the doctors are rotating through. So also the nurses have a strong role to play in antibiotic stewardship and rational prescribing. Regarding the training, there's lots of need for training across all the sections, not just IPC, but obviously the stewardship and diagnostics. If I concentrate on the IPC, I know that each of the sections has been doing a lot of work. There's been a lot of additional COVID-specific training, but what does that look like in the field? It can be anything from face-to-face training in sessions or bedside training, and to more formal sitting down in virtual classrooms. At the moment, OCA is working with the MSF Academy and putting a pilot forward for IPC training and antibiotic stewardship training. It's a diploma course that's going to be piloted hopefully beginning July with some clinical mentorship alongside it, so that we've got a virtual 2 courses in to access the teams who cannot leave their countries to get out. So we're going to be doing this vocational training so they can be in their work environment, trying to implement items that they're learning in the course along the way around either IPC or stewardship. Many of them will have been exposed to lots of the items in the training, but for some of them it will be very new and the most supported that they've been. Yeah, that's it for the training at the moment for me.
Mm-hmm. Okay, so some initiatives are currently being developed and will be starting. I don't know, maybe from the external perspective, Mike and Uduak as well, how would you see training, or for example, Uduak, in your context, training, how is that organized, or what do you see as challenges for training?
Thanks. So usually people involved in infection prevention and control in hospitals, especially when it comes to cleaning, are not really overlooked with training. So if there are training opportunities, there may be for doctors, clinicians, and other categories of senior healthcare workers. But the cleaners themselves don't always have adequate cleaning on what's on how to clean. Sometimes the cleaning products themselves might not always be available, or they might not. Might be substandard, and so are they killing bacteria, or they are rendering them inactive? So those are more things that really need to be looked at. And I'm going to be looking future. I have a study I'll be starting very soon about training cleaning champions. So we have training cleaners and the nurses who also participate in cleaning, giving them training on what is considered to be adequate cleaning, looking at cleaning materials. So I think this is really important. As I said before, that visual cleanliness doesn't, equate to microbiological cleanliness. And so a lot of our wards might be cleaned regularly, but are they really, we can't have a sterile ward per se, but there is an acceptable background level of contamination. So training is very important in this regard.
Okay, thanks for that answer. I don't know, Mike, if you want to, maybe from your perspective as well, how do you see training, all training of these different disciplines, pharmacists in stewardship, for example?
So obviously, clearly, it's also developing the training tools and then trying to, or as MSF and others doing, which is maintaining those, year after year, is always very difficult. And so I think one always looks for new opportunities for trying to enhance training and try and develop those opportunities. So for us, I think, for today, I think the launch of the WHO antibiotic handbook, guidance, is going to be 36 in different infections. Do you treat, do you not treat? And I think that provides, and obviously, opportunities not only into talking about what antibiotic to prescribe, drug, dose, and duration, but also when not to prescribe as well. And so I think it's therefore, would be happy to chat to MSF further, offline. But I think that provides a good opportunity for trying to think about what are the training needs and how you can wrap around, recognizing that MSF have their own guidelines, as I'm aware, but other opportunities of thinking about providing more information about are those right for you and do they fit your country, and if they don't fit your setting, then why don't they fit your setting, and trying. So though many of these guidance and WHO documents tell you a little bit about what to do, they don't really explain about what the background is and what the information is, and trying to provide more information, because people don't necessarily always be happy about prescribing really narrow spectrum antibiotics. Is that safe, and is that appropriate? And so those are the opportunities that one should take and to try and keep building better training resources over the future. Thanks.
Okay, thanks, Mike and Uduak. I think we have to wrap up slowly. So I have maybe 2 more questions and then we'll wrap up. Maybe a short question, but this can maybe be continued offline as well. But the question for Nada was concerning the application, the Antimicrobial. Can you just maybe briefly, in a few words, explain what it is and how this can be used in MSF projects?
Merci, Jorgen. L'idée de l'application Antibiogo est venue du besoin du terrain et c'est lié à la formation, puisqu'on a constaté...
It's associated with training. As we went with the implementation of microbiology labs in OCP, we realized that it is fairly easy to train technicians in the lab to perform the test because we've got simplified procedures. However, it's very difficult to turn them into microbiologists. These highly skilled microbiologists are not available in the majority of countries where we work, or they work in teaching hospitals. So with Antiglobo, it's the idea is to make it possible for lab technicians to improve their interpretation of microbiology results, which is the big difference here in these microbiology labs. You have to deliver the results with their interpretation of drug-sensitive tests to the clinicians. So with this app you can take a picture of the Petri dish, measure the inhibition diameters, and then apply the various interpretation rules from the microbiology learned societies. And of course, it doesn't mean that this replaces microbiologists, but it saves time. Because we know that if we're not taking action today, there'll be 2 million people dying from ABR by 2050. So you can't have microbiologists everywhere. So with this app, it's possible to deliver high quality results to clinicians. And on top of the lab and interpreting side, there's also some guidance for treatment, because we merged MSF guidelines with this app that gives you microbiology results. So instead of having drug sensitivity tests that are in so many numbers, you get the antibiotics that you can use. So the main user is the lab technician, but the end user is the clinician who gets a result which can be used readily and easily. Where can we find more on this app? Yes, on the technical IT side, some information is available online. And we are currently assessing this app to get the CE marking, because it's considered to be a medical device. It's being assessed in 3 different countries, and you can log on to MSF Foundation website, and also Antiglobo, which is the website dedicated to this app.
So I think one last question, because we really need to wrap up, but I think it was one of the first questions coming in. Like, okay, but what now in my project? I do not have access to culture, so how can I still improve stewardship, prescribe antibiotics in the correct way, etc. So I think it's a more general comment that has been mentioned already a couple of times. So I don't know if anyone wants to add something on that one. What to do if I don't have microbiology? So I don't know who wants to answer to that. Probably not very easy question.
I can start if you like, Jorgen. It's Mike. So, so to be simple, you do not need microbiology to take forward, stewardship context. So if you consider children coming into hospital, obviously the commonest cause of admission is, severe lower respiratory tract infections, for example, where the guidance is relatively, guidance is relatively clear. So actually, microbiology is important, but is important obviously for considerations of sepsis, severe abdominal infections, urine infections, but for skin and soft tissue infections, for much of the lower respiratory tract infections, actually the microbiology doesn't add, particularly because it's pneumococcus or Staph aureus as well. So I think and also if you look at the nearly half of the hospital prescribing is actually not dependent on microbiology results for taking forward stewardship interventions. So there's a lot that you can do without the microbiology data. And as we said, even with microbiology data, it's extremely important for improving clinical care, but then just the use of that data to use guidelines and elsewhere is much more complicated. So I think, in fact, you can produce quite significant stewardship interventions without microbiology data, as many centers have proven and shown, including in MSF centers. Thanks.
Okay, Mike, I think that's already a nice start of the wrap-up. I'm afraid unless Jane has one last thing to say, I don't know if you want to, and then we really need to go to the wrap-up. Jane?
Yeah, I would like to just do a round for IPC. So there's many activities that can be started with IPC that can help with the rational prescribing. So we're thinking about, if you're unsure, then you can reach out to your MTL or PMR and discuss what it looks like, and they in turn can talk to the Medco and even get headquarters involved, again at the multidisciplinary level at headquarters. It might be your pediatrician plus your antibiotic steward plus your IPC advisor who are getting involved if you see something that's going on or that they think that something can be done in your project. So don't sit back. There's an opportunity to always be improving our patient care, and also with that, the skills of our teams in the projects as well.
Okay, thank you very much. I think we can go to the wrap-up now. So again, first of all, thanks for everybody for the questions raised and for the panelists for their feedback and input. I don't know if you can project the next slide, please. Yes. So I think, well, these points are probably quite obvious now after the discussion we had. So what we wanted to have as takeaway messages is, well, the strategy of MSF to address AMR includes several pillars. So it's about infection prevention, control, stewardship, and move towards microbiology as possible. But as mentioned by Mike and some other people, things are possible without microbiology. It is a multidisciplinary approach, definitely. And again, the pharmacists are part of this multidisciplinary approach. I think we need to include them. And also maybe the role of the pharmacist in MSF, maybe move away from the supply pharmacist to really the role of clinical pharmacist, as mentioned by Amel, I think. We have tools. I think we have spoken sufficiently about PPS and CIPCA tools. These tools are available, so please check with your advisors if you want to have more information on the tool, how to use the tool, how to interpret the tool, etc. And these can be really integrated into routine activities. I think it's important to say that it's not just about ABR. I think it's really about improving quality of care, not just for the sake of ABR, but we really want to improve patient outcomes and quality of care.